All right. Hello, everybody. This is Sam Vance with the EMS for Children Innovation and Improvement Center. To be respectful of everybody's time and to get started on time, we're going to go ahead and start. I will let everybody know that we are recording this webinar. If you are not speaking, please put your phone on mute. And if you are connected through the speakers on your computer, please mute those speakers as well, as we tend to get a lot of background noise with that. So, thank you. So just to give our HRSA disclaimer that I think most of you are familiar with, you all know that we do receive our funding through the HRSA EMS for Children program, and that the information or content that you will hear today is not necessarily an endorsement from HRSA, HHS, or the U.S. government. And again, I would ask, if you are not speaking, please put your phone on mute. If you're connected through your computer, please put your speakers on mute. And I'm going to have to take a second here while I try and figure out who is on their computer and not muted so I can mute your speakers. Okay. So, please, if you are on your computer, please mute your speakers.
This is Catherine. I was trying to join the WebEx meeting that I had from Cassidy Penn, and it's not letting me in. Was anybody else having problems with it?
Not that I have heard.
Okay, it's just me. I love it.
Did you click on the link?
Yeah.
Did you join as a participant?
I am trying to reload WebEx, so I should be on shortly.
Okay. Well, we'll still be a couple minutes before we get to your part.
Fabulous. I'll be listening.
All right. Thank you. Okay, so I apologize to everybody for all of the technical issues here, but we will go ahead and get started. I just want to give you all a little background on the pre-hospital pediatric emergency care coordinators, for those of you who may not be as familiar with it. In 2007, the Institute of Medicine recommended that EMS systems appoint a pediatric emergency care coordinator to provide oversight to the care of children, to promote the integration of pediatric elements into day-to-day service, as well as local and regional disaster planning, and to promote pediatric education across all levels of EMS providers. In 2016, the NAEMSP released a position statement which acknowledged that a PEC may augment the EMS system and advise the EMS medical director. And it acknowledges that a PEC is associated with improved documentation, improved clinical management, and increased staff awareness of high-priority pediatric areas. And in 2017, the resource document, Coordination of Pediatric Emergency Care and EMS Systems, was published in Pre-Hospital Emergency Care. The conclusion of this document is that an EMS PEC facilitates the integration of pediatric needs into all aspects of EMS, and that EMS agencies may benefit from having a PEC based upon results received from pediatric verification programs for emergency departments. The EMS for Children program created performance measures to address the gaps in the delivery of emergency services to children. They also provide guidance on future areas for improvement. In 2013, the next generation of performance measures were developed with 3 new ones for EMS. Performance measure number 2 addresses the percentage of EMS agencies in your state or territory that have a designated individual who coordinates pediatric emergency care. The goal is to have 90% of EMS agencies across the country to have a PEC by 2026. With EMS providers having limited pediatric-focused education and infrequent encounters with children, particularly with the critically ill, there are gaps in patient care, patient safety, and clinical outcomes. To address these gaps, we saw that in 2007, the Institute of Medicine recommended that EMS systems appoint a pediatric emergency care coordinator to provide oversight to the care of children, to promote the integration of pediatric elements into day-to-day services, as well as local and regional disaster planning, and to promote pediatric education across all levels of EMS providers. However, these gaps in care still exist. So we saw that the NAEMSP developed a position statement, a resource document was developed, and there's a joint policy statement that will be released very soon. But in spite of all of that, you can see here that from the EMS for Children 2017-2018 EMS survey that only 22.9% of EMS agencies surveyed currently have an individual who coordinated pediatric care for their agency. In response, the EMSC program began the Pre-Hospital Pediatric Emergency Care Coordinator Learning Collaborative that started on October 1st of 2018 and ended for the state partnership teams on March 31st of 2019. Sarah from HRSA, are you on the line?
Yes, I'm here.
Okay, I will go ahead and turn this slide over to you then.
Sure. Sam, did you want me to go through and introduce everybody, or can I just say a quick word?
Either is fine.
Okay, sure. So now that I have the microphone, I just wanted to say a really quick word of acknowledgement to both the project team and to the grantees who completed this work. We asked for something that was significantly challenging, which was to complete or make a significant amount of progress on establishing new pediatric emergency care coordinators in just 6 months. And the work that this team and the grantees were able to accomplish is just staggering. It was really incredible to watch, and I just wanted to give them a shout out for the tremendous effort that they made. The smiling faces here you can see are the project team, Dr. Macias, Sam Vance, Terry Fisher, Rachel Alter, Cassidy Penn, and Dr. Auerbach who served to make this all happen. So they're definitely the superheroes of the effort from the EIIC side. Sam, do you have anything else you want to add?
No, that was great. Thank you.
Sure thing.
In addition, we had our advisory committee, which consisted of representatives from the 10 national organizations that you see here. We also have our subject matter experts, and you may notice that most of them are authors on the documents that we saw just a little while ago. And Travis Adams is actually a PEC from a very successful program in Gaston County EMS, North Carolina. The purpose of the collaborative wasn't only to increase the number of PECs within the states that participated, but it was also to gain information such as who serves in the PEC role, what are their responsibilities, and what are the benefits of having a PEC. Resources developed from the collaborative will be shared with all of the state partnership program managers. The focused aim was that each state was required to establish a target number of EMS agencies that will establish new PECs across the project duration. At a minimum, this target must include a majority of state EMS agencies that reported not having a PEC but indicated an interest in adding this role on a 2017-18 EMS survey. The collaborative consists of the 9 state project teams you see here, and the teams are comprised of the state EMSC program manager, at least one PEC, and other state and local partners. And these states represent 10% of EMS agencies within the United States. Through the collaborative, we held 6 virtual learning sessions and 1 in-person learning session in Austin, Texas on January 31st and February 1st. Each team reported on their current status and progress using electronic storyboards. We also held brainstorming sessions to identify what we've learned since October 1st regarding roles and responsibilities, education, how the state teams have been performing outreach to recruit new PECs and resources developed and needed. Some other topics that we covered included how to develop and deliver an elevator pitch, and we also had some breakout sessions that covered scenarios, skill check sheets, simulation, social media use, and dissemination. And the meeting concluded with a presentation on sustainability of their programs. Throughout the collaborative, we also conducted site visits with our state partnership teams to give additional assistance with topics such as dissemination and sustainability, as well as going over more in depth on quality improvement methodologies. We will be developing a collective action plan representing the common methods and aims used for outreach to EMS agencies that were used throughout the collaborative, and this resource document, as well as other resources developed from the collaborative that can help other states and territories understand how best to help EMS agencies adopt these interventions, are now available to everyone on the EIIC website. One of the charges of the collaborative was to define existing characteristics of a PEC, standardize the PEC qualifications and roles, and this definition was shared with all of the state partnership program managers within the last couple of months. The intent of designating and developing the role of a PEC is to ensure that there is a dedicated individual or individuals identified at the local EMS agency that represents pediatric interest and performs the roles listed on the following slides. Lots of creativity can be used in providing a PEC and broadening the scope. An agency doesn't have to have a singular person performing the functions of a PEC. The responsibilities can be fulfilled by 2 or more people, such as the medical director, EMS chief, training officer, or other pre-hospital professional. Additionally, there could be a region-wide individual or individuals that performs the responsibilities as a PEC for EMS agencies within a region. Some of the responsibilities of pre-hospital PEC are that they ensure that pediatric perspective is included in the development of EMS protocols, ensures that fellow EMS providers follow pediatric clinical practice guidelines, promotes pediatric continuing education opportunities, oversees the pediatric process improvement, and ensures the availability of pediatric medications, equipment, and supplies. Promotes agency participation in pediatric prevention programs, promotes agency participation in pediatric research efforts, liaises with the emergency department pediatric emergency care coordinator and helps close that feedback loop with the hospitals, promotes family-centered care at the agency. So some of the main ideas that were learned from the state partnership teams that was brought out in our in-person meeting in Austin was that we need robust, well-developed toolkit for educational resources, assemble project templates, the quality improvement, performance improvement templates with core measures to match with performance measures and pediatric protocols, and that PECs should be partners across the continuum and at the leadership level, and that the PEC role can be accomplished by any level of care, including the volunteer level, as long as they have an interest in improving pediatric care, and that dissemination of the program involves the MSC program managers to include usage of social media, EMS recognition programs, and public relations. Despite the challenge of having an aggressive timeline, the 9 participating states have been able to increase the number of PECs within their respective agencies, and the information that you're going to see here is current as of March 31st and is taken from the information reported by the state partnership team leads. So 369 is the goal submitted by the states, is 50% of the agencies expressing an interest in having a PEC. And as of March 31st, you can see that a total of 340 new PECs, or 92% of the overall goal, have been recruited, which is a pretty amazing job for such an aggressive timeline that we've had. So our state teams really outdid themselves, and congratulations to all of our state partnership teams for such a great accomplishment. With that, I'm going to turn it over to Catherine Schaefer from New Mexico, and she's going to talk to us a little bit about what she did in New Mexico. So, Catherine.
Hi, thank you, everybody. I I just want to thank the EIC and everybody involved for this amazing project, because it really pushed New Mexico to the next level to move forward. I think it was the aggressive timeline that kind of put the fire under us to get us going. With that said, I want to thank some people that are part of our core team. Dr. Robert Sapien, of course, as our PI, Scott Oglesby, who is our statistician, Amy Pottinger, who has just been outstanding in putting everything together for us, Chad Kim as our fan rep, who is also an EMT, and Bellows, who is an EMT and educational coordinator, and then Leticia Otero, who's our administrative assistant, who just helped keep us all together to push this process forward. So next slide, please. So our overall goal in New Mexico was to increase PECs by 10% of those who had responded that they had PECs. So we had 49 people who had PECs, so our goal was 5, and we met that goal. We did do a kind of a bottom-up approach with this by working with our EMS conferences and our EMS regions to really create our collective of brains behind the New Mexico PEC program. Next slide, please. So we're still collecting data, and we're still trying to confirm all of our PECs and everything. And we have 22 as of late yesterday evening and early this morning, 22 new PECs in New Mexico, and 21 confirmed of the 49. So our numbers have increased. As I've been having people make calls here to still try and increase the number of PECs, we are continuing to work with the New Mexico EMS Bureau, who is going to be asking, through some consternation of our EMS services, our service report already asked several questions, but they have agreed to answer 3 more as to if you have a PEC and who that PEC is, and to get the medical director to confirm that position with your EMS agency. So that will actually go into the next year's cycle of questions, which will be in fall of 2019. So I hope to have a larger increase in number of HAZPECs by then, as we continue to go out to our EMS meetings and really pitch having a pediatric emergency care coordinator. We are using a recognition system, which is self-designated. So we have 3 tiers to that. We are kind of using some of what Kansas has done, and we're looking at, gold, silver, and bronze stars. But that really, that concept came from our grassroots approach and all of our pediatric super champions that were created in February at our focus group. If we go to the next slide, we can talk a little bit more about that focus group. So I think if you'll just click through all those, we can get through that. I'm sorry, that was part of my slide. So in that, we did what was called a facilitated discussion. And so we were very careful to invite a large array of people to this. We had some very specific questions developed as this focus conversation evolved, about giving them the background about what a pediatric emergency care coordinator was based on the HRSA suggested list of PEC roles and responsibilities. So we went through that, and then we asked some very specific questions about, what did you hear that stands out? Did you hear anything that was particularly interesting? So we really drew on their information that they heard and where they wanted this to go. So the questions are objective, reflective, decisional. And so when we got to the decisional questions, we were able to ask this group of 26 participants of which of these responsibilities do you see yourself working on, what roles do you really care about, so that when we were pushing this forward, we were pushing it forward based on what those grassroots people thought was important as a group, and it was well represented in that we had people who were medical directors, from first responders through medical directors, chiefs. So it was a really nice array of participants, so we could get a good feel for what we could push through as a state. And based on that, we were able to come up with some key concepts that we are using for our tiered group, and they were really responsive to that concept. We paid for their time. They gave them incentives to participate in this. We are still giving out lottery and conference registrations for people who respond to surveys, and we're trying to keep them engaged with tiny little, I want to say prizes, but I'm sure there's a better word for that, just so that when they come to a meeting or when they come to a any kind of workshop that we have about pediatric emergency care coordinators, that they're taking something back that shows them their time was valuable to us. So we're also providing free CEs to any time we discuss the PEC Collaborative. Next slide, please. So we've really talked about a little bit about what the focus entailed, but there was a lot of pre-work that went into that. We had pre-surveys done in 4 different conferences, and we had about 97 responses to that. And while it was kind of disheartening that some of them hadn't heard of EMS for children yet, there was a large percentage who had not heard of it. It was kind of nice to know that people who did respond to that were very excited about the Pediatric Emergency Care Coordinator. And so from that list, we are also including them on anything we develop, giving them our resources, sending out the toolkits. So if they responded to anything regarding this PEC initiative, we are keeping in the loop and giving them free materials. And anytime EIAC sends out something about a webinar, we are sending it to them so that they're involved in the process still as we're moving this. Next slide, please. So the goals overall for the PEC Learning Collaborative were that we would create a program that was based on the feedback of the local working groups or the statewide working groups, and make sure that we had the earnest buy-in, and we are really seeing that. It is really happening for us, and it is very excited. So we think that we have done a fairly decent job in these last few months of getting our information out to a large portion of the state. So every time we're coming out to a conference, whether it's on the Navajo Nation or it's down south in our southern retracts, that are partnering with El Paso and some of the Texas hospitals, it is really nice that we're bringing the same message to those groups. Arizona is doing a good job about their partnerships. Texas, we are mirroring their recognition program. When Joe Santos was there, he gave me his recognition program, so we're mirroring that program so that when we're in those areas, it's kind of like we're speaking the same language, and they're understanding when they're working with our New Mexico providers that we're all on the same team. Our workshop question was, as healthcare, and this is the next slide. So as healthcare providers, medical directors, or state leaders, how do you see the role of pediatric emergency care coordinator evolving in New Mexico? And that's what we're still taking out to our services. How do you see your role in this pediatric emergency care coordinator? And we've changed that lingo to be, instead of a PEC, to be a pediatric champion, and it's been more accepting. And as we make this our opening dialogue, we are able to have that conversation with that service and let them decide, where they want to be as far as being pediatric champions. So we're really excited to see what the end of 2019 brings us, with a couple of more pieces to the puzzle coming together in our PED skills assessments that we're providing. If they're engaging in this PEC concept, we're providing them with lots of information about the scenarios and free things that they can get as they become pediatric champions. So the closing remarks for New Mexico is that really developing our super champions from the workshop has been ideal, because that is creating a listserv where people are actually exchanging ideas, and other places that had PECs are reaching out to those who didn't have PECs that are within their community and saying, we can help you with this part of your recognition process or designation process, that we will help get education to you. We'll come out to your communities. the overall concept of pediatric champions is really moving forward with services and dovetailing well with facility recognition, and that communities are more moving forward in concert with the EMS, so that when I'm going out to communities, I'm now doing two things at once, EMS and hospitals, and it's really nice. We're excited. We're committing now to future participation in all the trainings that are coming up. We're sending out people who have been the super champions to go and talk at their local retracts. So it is kind of like a little spider web. It's getting all over the state, and we're pretty excited. When Dr. Macias was out here and he brought the idea of the key driver concept to us, we've been helping with those services complete key drivers just when they start thinking about being pediatric champions, so that they can see how those concepts are moving into action items towards the end, if I'm doing it correctly. And I hope to get some more information about that later, make sure we're on the right track with drivers. But overall, we've been very successful and had some really wonderful responses from our services when we get done presenting to them. And that's really it in a nutshell, the last 6 months.
Thanks, Catherine. You all have done a great job, and we will have time here at the end for questions for Catherine. With that, I will hand things over to Morgan Skaggs in Kentucky.
Oh, fuck, I don't want to listen to you. Hello, everyone. Apologize a little bit. It's springtime in Kentucky, so I've got a little sinus allergy thing kicking in pretty heavily. So when we looked at our data from the 2017 EMS survey, we had 21% of the agencies in Kentucky claim to have a PEC, 35% or 57 agencies that were interested, had 8 agencies that had plans to add a PEC, and then about 40% who had just kind of said, no, we don't have one in response to that question. And as we were developing our approach to this project, looking at our state, there is a regional structure that exists more in some areas than others. It's heavily used by the State Fire Commission and a lot of the fire training that's done around the state. Our healthcare coalitions under the preparedness program function on a regional level. But EMS had not heavily used that regional structure in the past, and so it was one of the things I wanted to incorporate into our work moving forward. And so I was able to take that state regional map and pulling some data out of our survey information that was in Tableau, was able to lift out a graphic with the PEC designation kind of in the shape of the map, and was able to layer that in and really get a visual for where the people were who were claiming to have a PEC currently and those that weren't. And it was reasonably well distributed considering some of our urban versus rural areas. Next slide, please. Our initial approach, we wanted to set up sort of 2 main teams, the primary learning team or the collaborative team, which would participate in the EIIC activities, looking at the online webinars, the in-person meeting in Austin, as well as an actual state project team, which was going to be made up ideally of one regional representative, an agency in each region who designated a PEC to participate in this project. And as part of that, we established a memorandum of agreement between that agency and our office, and some of the grant funding went to that agency in exchange for them designating a person to work on the project. The initial focus is really outreach and education, and we started just with emails essentially from me to the 4 different groups based on their answer to that survey question. We included the Fast Facts handouts, and we started setting up webinars and conference calls with the state project team. And the goal, we are in the process now of establishing regional meetings that I'll talk more about in a moment. We also have agency field inspectors that go out to every licensed agency in the state once a year to do an inspection as part of their licensing process. And so I've incorporated those field inspectors to do a short little, 5-minute education on the topic while they're there, to ask the agencies to designate a PEC, to leave some literature behind and instructions on how they go about designating that person, and that our office actually, beyond just the EMSC program, encourages their participation, although it is not mandatory. We do strongly encourage it. Next slide. Some of the initial challenges and lessons and sometimes solutions that we ran into. Our initial plan for the collaborative team was for an agency PEC to pretty much make up the bulk of that team. And as we started participating in the webinars and the online calls, that wasn't quite the group that we needed. So we did sort of reorganize that team a little bit and go a different direction with it, which allowed me to increase the number of people on our state project team. When I did solicit agencies across the state to apply to be part of that state project team, the response was uneven. We would have some regions that would have 4, 5, 6, applicants, and in other regions that didn't have any. So we had to kind of loosen those regional boundaries a little bit and get a bit creative to try and get the geographic spread that we were interested in. We also had some delays with just the red tape, the internal processes, the hoops that we have to jump through to get those MOAs in place. And certainly I've learned a lot more about our internal processes through this project, and would certainly know a little bit more going into it next time, some things to keep in mind and a better feel for the timeline that would be needed to do that. I also learned that there were some documents that I've needed to complete this process, such as a substitute W-9 and signed agreements that I would actually in the future, if I were doing this again or a similar project, would actually make those part of the application process and require those up front to save time on the back end, as well as really help determine who was serious about participating in the project. We knew going in that our time frame for this project was really short, and so certainly here within my office, I struggle with competing interests and other projects that are demanding of my time, and having time set aside just for this is a struggle. And we also knew that the work was going to carry over for a much longer period of time than just the 6 months. And so when we set up our MOAs with the agencies, one benefit to doing it that way is I was able to expend a significant portion of the grant funds within the required time period, but the MOA is written so that I actually locked in those participants for another 9 months. So I actually have them engaged in the project throughout the calendar year 2019. We did have poor response to some of the initial emails to the agencies who claimed on the 2017 survey to already have a PEC. And so we certainly learned from that process that self-reported data is unreliable, and for my purposes, I don't actually consider an agency having a PEC until I've confirmed and have a name and contact information for that individual or individuals. Scheduling groups and meetings for a large group of people, trying to pull together 16, 17 people is a challenge, and we have found that having those meetings through a webinar or GoToMeeting type platform allows us to record the information and make sure that it is available for anyone that was not able to tune in live during that time period. Next slide. So the emails that I initially sent out, and the box on the right is actually sort of the content of the email that went out to the group of agencies who claimed to already have a PEC. And make sure that, try to get them to answer, and we did send the fast fax document with that. And the emails were worded differently for each group, but they were similar in content. Next slide. Record keeping or tracking was a big part of the process, and so these two small pictures in the middle of the screen kind of refer to the spreadsheet I had set up, and I kind of like to color code things so that I can see them quickly at a glance. But I was tracking the agencies, what region they're in, whether they had a PEC or how they answered that 2017 survey, whether we had confirmed the PEC or established contact with a new agency in the PEC, and it kind of tracked when we were able to add those individuals based on kind of what time period and what they were responding to. Within our licensing system, we have an image trend product that we use to manage all of our licensing, and we were able to set up a designation for the PEC coordinator. And so as we indicate within the agency account who the agency director is and who the medical director is, we're also able to indicate who the PEC coordinator is, which allows me to pull a nice report with just a couple of clicks, and I can have a current report of the PECs and all of their contact info. And then I kept a small little quick chart to track the number of agencies that had responded and established a PEC based on those different categories and responses to different events as we moved along. Next slide. As I reached out to the field inspectors as well as continuing to do outreach through our state team, I did borrow a few documents from New York following the January meeting and created sort of an updated fast facts just for us that really honed in on the information that was most important when you've got people that are really going to glance at something quickly. I wanted something that would grab their attention. And noting that we've actually already need to update this, the percentage in the corner is a little low compared to where we stand currently. But that state team has continued to meet through an online process, and we're currently in the planning stages for those in-person regional meetings where we will invite every agency in the area who either has already designated a PEC or ask them to send somebody to come hear about why this role is important and the benefits that it can bring to their department. And then also, we would like to invite any hospital PECs that are in that area, as well as medical directors if they would like to be involved, and really an opportunity for these individuals to network and talk about some of the challenges in their region to improve pediatric care. And a real focus that's come out of our early conversations is on increasing pediatric education availability. So we are looking to hold a PEP class, provider class specifically for the members who are on the state team to give them the first step towards eventually becoming instructors themselves. And then we're trying to coordinate with the agencies that have instructors in the classes to increase the number of PEP, PALS, and PAIRS classes, not just within their own services, but that they open those up to neighboring services. And then we will be establishing some regular PEC meetings, both at the state level as well as regionally. Eventually, we will have an annual PEC symposium. And we do have a web page geared towards the EMS PEC coordinator that continues to evolve. Next slide. Some things I wish I had in the beginning, certainly more time prior to the launch to get some of these. A lot of this sort of happened on the fly. While we had an initial plan, things changed, and you learned lessons both from your own work as well as the other members of the collaborative. And so a little more planning in advance would have been helpful. I'd like to have had maybe a slightly more polished record-keeping process. I know as part of the collaborative, they were looking to gather information in a way that lets them compare across all of the states involved. And I already had a fairly robust system that I was using, but doesn't necessarily equate to what people in other states were using. So having the spreadsheet that the EIC designed would be helpful if you were just getting started now. I really wish I could have pilot tested within one region before trying to go statewide. I think I would have learned a lot of things from that smaller pilot test that would have been helpful. And then another document that I borrowed from New York, I tweaked it and changed it and made it applicable to us, but especially with our field inspectors bringing this up, they needed a couple of things they could leave behind, and one of those is a PEC designation form. now that they can fill out and send in to me directly so that I have all of the applicable information. Next slide. Some tips or things that I would share with others is to certainly make this achievable. Some agencies look at the list of responsibilities or qualifications for the PEC, and it seems a little intimidating to them. And so we've actually added to our website the statement that, these responsibilities and qualifications are suggestions, and we don't want it to deter anyone from participating for fear that they don't meet some or all of those checkboxes, and that the most important thing is that they have a desire to improve pediatric care and a willingness to engage in information sharing. And that if we start together taking those first steps, that we'll continue to work together to bring that improvement to the table for all of us and share that information. And I've really kind of highlighted that that's the single most important piece for this role, is to be willing to share information, both information that I send out that they can disperse within their department depending on which direction it needs to go, or coordinating and sharing with each other, or reaching out to me for questions or things that they need help with. So finding the audience was important. With a lot of our agencies, the directors are very proactive and want to be engaged, and they'll say, sure, I'll be the PEC. And to be honest, I don't necessarily want the agency director to be the PEC because we already have challenges in competing for their time. So I'm really encouraging them to find someone else within the department. But for the agencies that don't respond initially, the director is getting those emails and not doing anything with them. If I can reach training officers and sometimes even first frontline personnel within that service and get them interested, a lot of times then they go to the boss and say, hey, we'd really like to do this, or I'd be willing to step up and do this. And once they have someone willing to take it off their hands, sometimes that speeds things up. So certainly we share this information anytime we get an opportunity, social media, through our newsletters, training events going on around the state. If we have the chance to go, we do so. And then promoting the program through any means necessary, or sometimes that you just have the option. And competition can be useful in some cases. We had some equipment that we were going to distribute, and one of the things I did was I made sure that announcement that this equipment was available and how that application process worked, that went out initially to the agencies that had a PEC. And in this case, naturally, that equipment went very quickly, and we were able to share that through the K-Beams Facebook page that we had done this, and that this information went out to that group first. And so that if you are interested in finding out about these opportunities, the best way to be first in line is to have that PEC and engage in the information sharing that we're doing. Next slide. So our original goal was to establish 48 new PECs, and we've come really close in that we've established 44. Now that was well above the 50% of the initial 57 that had indicated an interest. But we were trying to set the bar really high and push ourselves to add a significant number of PECs. And the day I finalized the slide set last week for Sam, I actually changed this slide out twice during that process because I got new information. And I've actually had another PEC added since this was finalized. So our total number now of confirmed PECs in the state is 64. We found some of the same things that New Mexico did, that the number of agencies who previously said they had a PEC, only a smaller number of those would actually confirm and share that contact information. But we added 44 new, as well as confirming now 20 of the original 35. So our total went from 21% up to 38.5% of agencies in the state having a PEC. And that is all I had for you today.
Great job, Morgan. Thank you. Appreciate it. So, as I mentioned earlier in the presentation, the resources that we have been developing and collecting over the collaborative are now available to all of you on our newly revamped EIC website that just went live within the last couple of days. If you haven't had a chance to check it out, now would be a good time to go and take a look at it. Also, as an FYI, in addition to the plenary session we'll be doing at the all-grantee meeting in August, there is also a post-conference meeting on Friday from 1 to 4 where we will be taking a deeper dive into the collaborative as well as kicking off the pre-hospital pediatric emergency care coordinator community of practice. The space in the room is limited to 35 people, and we currently have 21 people signed up. So if you're interested in attending that, I would encourage you to go online to the registration that was sent out about a week or so ago and get signed up for that. With that, I am going to turn this over to Dr. Auerbach to moderate some question and answers here. Dr. Auerbach, are you on the line? Okay. Well, while we wait to see if Dr. Auerbach is on the line, he says he's muted. Let's see if I can. All righty, Dr. Auerbach, hang on. I'm going to see if I can find you here. Apologies. Try to find Dr. Auerbach here.
Hello?
Hey, there you are.
Hey, I just hung up and called back in. That always works. Hard reset. So thank you so much to Sam, Catherine, and Morgan for a really fantastic presentation, and to everyone for their really hard work during this collaborative. I'm happy to facilitate some discussion now, and it looks like we already have a question from Lenora. If others have questions, please go ahead and list them in the chat box. And please, at any time, feel free to reach out to our team, to Sam, myself, Terry, and we can help to connect you with, and Rachel, and connect you with different people involved in this project. So Catherine and Morgan, do you have any lessons learned or ideas to pass on to other states who want to increase the number of PECs at their agencies? And this is a question from Lenora.
Morgan, do you want to go?
I was waiting for you.
I think the only thing that I can think of is that utilizing, if it's not exactly like that workshop question, is broaching it from, like, you know, with your expertise and your putting in them as a healthcare provider, you know, how do you see this working for you? How do you see giving them the background and then letting them decide where they want to go with it? It's total buy-in then, as opposed to me saying, hey, this is what we're doing here. This is what we think needs to happen. Come on board, you know, and putting it on their laps. I give them the information, and then I say, well, how do you want to do it? And that's it. That's all I had.
Yeah, I mean, I would second what Catherine had to say, as well as, I mean, some of the things I mentioned previously. It's kind of in part is finding out what in your state is most attractive, and what is the strongest inducement to get people on board. And again, when I have trouble getting through to an agency through the director, finding other people that work there that are interested in are willing to step up and take some of that on can be a good way to get your foot in the door, and highlight the fact that, you know, you don't have to be an expert at everything and feel like you can run the show by yourself on day one. It's about being willing to step forward and share information as a group and work together.
Thank you so much. I think that's a great comment. And Teresa, T mentioned, as with many EMSC initiatives, state partnership program managers work tirelessly to make improvements. And can we share how much time would needed ahead of a launch? So I'll dovetail and then put some comments that back to the group. But just to dovetail with the comments that were just made by Catherine and Morgan, I would really encourage people to recognize that this is a marathon, not a sprint, and that if you were to look back at many of the 9 states that were involved in the early parts of the collaborative, many of us felt like we wanted to give up and that there was no end coming along the way, and we learned from each other. And I think that using a multifaceted approach and leveraging lessons from other states and other areas, but then at times trying to get creative and match your own users' needs. So I would strongly suggest patience and collaboration, but the approach that we had with funding led to a little bit more of a rapid engagement of PECs, and I think that was because in these 9 states there was dedicated time to focus on this work. But I think that for other states, my suggestion, and I'd be interested to hear from others, would be trying to be patient and recognize, as was stated, that there's a PEC out there in, I would say, every EMS agency, and finding them and potentially grooming them. They might not all know that they're supposed to be a PEC yet. Any comments from others about that sort of the question of how much time? So if I try to give an objective answer to T's question, I would say more than you think, and starting somewhere and trying to set some short-term goals. I think awareness about PECs and really potentially aiming for, for many months, if not years, to have this happening across the state, as opposed to thinking about it happening in weeks.
Are all of our phone lines open?
Yes, go ahead.
Okay, this is Tracy Cleary. And I would also say, here in Kansas, I would also say that this is why it is so important to have those relationships built with the EMS agencies now, is because when we have projects like this, that yes, you guys were tasked with something so incredibly quick. And I mean, Catherine and Morgan, I know I've talked to other states that have said, had it not been for those relationships already built with the EMS agencies, asking them that and to move that quick never would have happened. So I would also say that on top of having those relationships, we want our surveys to be done every 2 or 3 years or now annually. Having those relationships and coming to them and asking them this is a little easier to do when they know you. It's a familiar face, a familiar voice. And then Mike, I see your question. Can you briefly describe again what you found out when you reached out to the agencies who had indicated on the 2017 survey that they had a PEC, and what did you ask them and what was their response? I did a secondary survey in December of last year to kind of see where we were because we weren't able to be in this collaborative. And I'll tell you, there was some misunderstanding of the survey in 2017. So the drive that these states have done and all of the support that you guys are giving each other trickled down to the states that weren't involved in the collaborative. And I used it as my own push to do that survey and started using some of the lingo and language that you guys were using and have made vast improvements in the PECs here. So yes, they answered those questions in the 2017 survey, but again, it was those relationships I had built that they could call me up and we would discuss immediately, well, what did that actually mean? It doesn't mean hire a new person just for this specific role. It means you have that advocate, just like Dr. Auerbach says, you have that advocate already there that's passionate. They just might be a little scared to speak up, and they just need that extra nudge. So I would just add that too. So Morgan, Catherine, would you guys agree on that, or any of the other managers on the phone?
So Morgan and Catherine, this is Mark. I put the question out there about whether or not the individuals at those agencies turned over. I think that at least that was something I was hearing both on the pre-hospital and hospital side with this work, is the amount of turnover. I really like the idea that one group of individuals brought up of having a backup so that there's not just a PEC, but potentially another individual should that individual leave the agency. But with the response to the survey, I think one challenge was individuals potentially not understanding what a PEC was with the first go around with the survey, and another challenge was potentially turnover. So I'd be interested to hear if others had experience or strategies to the amount of turnover and how to address that.
Dr. Auerbach, this is Catherine again. Because we were running into that problem with our follow-ups to see who was still there, when we looked at Morgan and Tracy's, not only their PEC stuff that they were doing, but their FRC, they always had additional people listed. So we included that as a way to address that issue. We included having the medical director listed on there as well as their chief or their EMS director, so that we had multiple people that we could include in those emails or the follow-ups to make sure we were hitting somebody at that agency.
And this is Morgan. We certainly run into turnover problems in our hospitals, more so than we do within the EMS services. As far as we do have the ability within our licensing system to designate more than one person as the PEC, and there's so far I've only got one agency that specifically requested that we list two PECs, but we can pull the agency director and medical director information at will as well. And so and I also know that terminology is something that's varied a little bit, and in some places, like Catherine has found, pediatric champion is more palatable than the PEC coordinator. We've chosen to stick with the PEC coordinator language, and I think you can do it either way. It does help if the terminology is consistent when it comes to things like surveys, and it would just require a little extra education maybe at the time that those go out. But if you're dealing with a consistent group of people as the PEC, then that certainly makes that easier. We found that some of the language where it said, within the PEC roles and responsibilities, it might say ensuring the availability of pediatric medications, equipment, supplies. And we found words like advocating for might sometimes be a more palatable language that people feel more comfortable tackling. But we haven't had as much turnover issue in the EMS side of the equation as we had on the hospital side.
Thank you for those comments, and I would say that theme of making this something that does not sound all-consuming is something that came up quite a bit, and again, getting people to commit to serving in this role and potentially scaling the role up over time, so whether that's through using a concurrent term like champion or pediatric emergency care coordinator, or even really saying you can start with these components and then moving on, sort of scale up and build up. Other questions or comments? I see a thank you from Jason. We're wrapping up to the last few minutes here, and really appreciate the opportunity to share with everyone, and just want to remind you about the time that we'll have in August, as well as the content on the website and the accessibility of our team as you work through this over the next months or years. Sam, any closing remarks? I guess we have another minute here. If anyone puts something in the chat box, I'm happy to bring it up, but we're getting pretty close to closing time.
No, I just want to say thank you again to all of our state partnership teams, and congratulations on such a great job. And we look forward to seeing everybody at the All Grant Team meeting, and hopefully we will be able to get a participation from a lot of the folks who weren't able to participate in the collaborative to stay at the post-conference meeting.
Have a great day. Thanks so much, everyone.
So thank you, everybody, and have a great afternoon.
Have a great week. Take care.
Bye.